Can a modified barium swallow study or a FEES actually help doctors diagnose medical conditions? Yes, absolutely. If you don't believe me, I challenge you to stick around until the end, then share in the comments if I was able to change your mind or not. As you might already know, MBS and FEES are instrumental evaluations of swallowing functioning. But in addition to giving us information about swallow anatomy and physiology, our instrumental studies can sometimes uncover unexpected findings that the medical team needs to know about and manage appropriately. These findings can be life-changing, from foreign bodies and loose surgical hardware to concerns for cancerous masses or the emerging signs of a neurological disease. Remember, dysphagia is a symptom. It doesn't just pop up for no good reason. Dysphagia occurs because of something else happening in the body, whether that's due to a stroke or because someone swallowed their dentures. I will add that sometimes we are faced with an idiopathic dysphagia in which the origin truly is not completely known. As SLPs, our job is to put on our best dysphagia detective hats, get to work, and share our results with the medical team so that our patients can receive the best care possible. And that's exactly what we'll be talking about today in this video. Here are 3 ways your MBS and FEES findings can help doctors diagnose medical conditions. Let's dive in. I'm Teresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the MedSLP Collective and MedSLP Education. Number 1, neurological findings. First up, let's discuss neurological and neurodegenerative disorders. SLPs are sometimes the first clinicians to encounter or suspect a neurodegenerative disease or acute neurological event. We have a unique set of skills that equips us to help with this. Not only are we the experts in dysphagia, but we're also able to piece together our chart review, cranial nerve exam, oral mechanism exam, and MBS or FEES findings to get a comprehensive picture of cranial nerves and the anatomy and physiology of a patient's swallow. Now, I'll share 2 stories with you where an SLP played a pivotal role in helping a patient receive an appropriate diagnosis. The first is about one member of the MedSLP Collective who shared a story in our private Facebook group about a patient who was admitted to the hospital with a mild facial droop, mild dysphonia, and complaints of severe dysphagia and vertigo. His head CT was negative, but the neurology team suspected this patient had a stroke. Unfortunately, the patient couldn't get an MRI due to having an incompatible pacemaker. Because of this patient's complaints of dysphagia and his suspicious neurological presentation, the SLP completed an MBS. She noted many of the typical signs of a lateral medullary stroke and Wallenberg syndrome, unilateral pharyngeal paresis, UES dysfunction, delayed swallow initiation, and posterior loss of the bolus prior to the swallow. The SLP alerted the primary physician and neurologist. The MBS further helped pinpoint the patient's area of infarct, suspected to be in the medulla, even though he wasn't able to have an MRI. The SLP's work here helped the patient receive an accurate stroke diagnosis and qualify for a rehab stay due to his stroke. Our second story is a bit different. An SLP saw a patient for an outpatient MBS after a referral from his doctor. His wife had noticed he had been having some occasional difficulty swallowing, mostly with liquids, but no one could figure out why. During the MBS, the patient demonstrated several signs typically noted with Parkinson's disease: lingual pumping, tongue rocking, oral residue, and delayed pharyngeal swallow initiation. The SLP recommended the patient see a neurologist due to these atypical patterns. His diagnosis of Parkinson's disease was confirmed a few months later. In the 2019 paper, Oral Pharyngeal Dysphagia in Parkinson's Disease and Related Movement Disorders by Kwan and Lee, they state that mild oropharyngeal symptoms of dysphagia were frequent in the early stage of Parkinson's disease, and dysphagia might be the first sign of that disease. This SLP story is the perfect example of this and how important our role is in advocating for our patients to get appropriate referrals for early intervention and diagnosis. Imagine if the SLP hadn't said anything or suggested a neurology referral. This man might have waited months or years to see a neurologist, only when his symptoms progressed further. Thanks to the SLP, he could get an early diagnosis and start managing his Parkinson's as soon as possible. Point number 2, structural findings. When we pay careful attention to the anatomy and physiology on our MBS and FEES, we can uncover anatomical abnormalities that can have a huge impact on the patient's life. Some examples include intubation injuries, vocal fold injuries, or laryngeal or pharyngeal masses. We might be the first clinicians to refer a patient to ENT due to concerns for a new laryngeal mass or vocal fold paralysis after intubation. These can be life-changing findings and require early intervention for the best outcomes. Number 2, foreign bodies. If you take the time to search any of the medical SLP forums online, you'll find multiple stories of patients who have swallowed their own dentures or something else equally inedible, only to have them later discovered on an MBS or FEES. A finding like this requires surgical removal and urgent intervention. The SLP plays a huge role in getting the patient the proper medical care they need in these situations. Number 3, mucositis or pharyngeal infections. Mucositis and infection processes like severe thrush, for example, can wreak havoc on the pharynx and swallowing musculature. An instrumental can help uncover these kinds of conditions and reveal the impact on the patient's swallow function. In this situation, the SLP can advocate to the physician for further evaluation and medical treatment of the pharyngeal infection or mucositis. One of the best examples I can think of where an SLP's dysphagia detective work saves the day is the story I'm about to share with you now. This SLP performed an MBS on her patient who was in inpatient rehab. He had sustained a traumatic spinal cord injury and underwent a C3 through C6 ACDF surgery a month prior. Across his prior 2 MBSs with other SLPs, he had significant prevertebral edema, but ENT, neurosurgery, and PM&R hadn't found a reason to explain this on CT or flexible laryngoscopy. During his 3rd MBS, this SLP finally insisted on an AP view. Lo and behold, a screw had recently dislodged from this patient's ACDF hardware and was resting in his soft tissue. The SLP and radiologist stopped the study and contacted the medical team ASAP. The patient required near immediate neurosurgical intervention to correct the hardware issue. Are you enjoying this video so far? I'll be posting other videos just like this one that you won't want to miss, so make sure to hit that like and subscribe button and turn on the notification bell. Also, do you have any specific questions about how your findings on MBS or FEES can help the medical team with their diagnostic workup? Leave a comment below and tell me about it. We'll be sure to get your questions answered as soon as possible. Make sure to stick around to the end to claim a freebie or 2. Number 3, esophageal dysphagia. ASHA acknowledges that the SLP plays an important role in identifying dysphagia in any phase. SLPs are frequently the first clinicians to come across the signs of esophageal dysphagia. So it's crucial for us to have a basic understanding of esophageal disorders and when to refer to our GI colleagues. If you want to boost your knowledge on esophageal dysphagia, I highly recommend you check out episodes 33 and 34 of the Swallow Your Pride podcast with Julie Huffman. She's an SLP with a special interest in esophageal dysphagia. Her episodes will blow you away. So what are some things we might see during our patient interview or instrumental that indicate esophageal dysphagia? On your instrumental, you may see contrast retained in the esophagus, contrast or dye flowing up through the UES, also known as retrograde flow. If you're doing an MBS with an AP view, you may see contrast retained in the lower esophagus when you move the fluoroscopy machine to get a lower view. And during your case study, your patient may also share common esophageal dysphagia symptoms, like gradual onset and progression of symptoms, especially if it starts with one type of food and then increases in severity and frequency with other foods and liquids. Family history of GI dysfunction. There are genetic links for GI dysfunction, including reflux, chest pain, and odynophagia, coughing, throat clearing at non-meal times or waking up at night. This is common with GERD. The sensation of food getting trapped or sticking, unintentional weight loss with dysphagia. This can be particularly worrisome for esophageal cancer. And those are just to name a few. Whenever you see signs of esophageal dysphagia on an instrumental and red flags during your interview with the patient, you know it's time to consider a GI referral so that they can have appropriate medical intervention. The story I'm about to share with you is a great example of how powerful our role really is and how much of a difference we can make in a patient's life and in their medical care. An SLP shared this with us in the MedSLP Collective. Earlier this month, I saw a patient for an MBS. He was in the emergency room due to a new onset of difficulty swallowing. The MBS was unremarkable in the lateral view. However, my esophageal screen found significant stasis in the distal esophagus. I recommended a stat GI consult and a CT. The patient sent me a message today thanking me for advocating on his behalf. Unfortunately, he was diagnosed with esophageal cancer last week. My heart is broken for this patient, but it's a reminder that the AP view of an MBS is so crucial. I can't help but think what would have happened if I had just done a lateral view or an upper esophageal or cervical AP screen, said everything was fine, and sent the patient on his way. What a powerful story. Each story I shared in this video today showcases just how important our role is and how MBS and FEES can help doctors diagnose medical conditions. If you have an interesting MBS or FEES story, I'd love for you to drop it in the comments. I've got a free gift for you over at medslpcollective.com. You'll get instant access to our free MedSLP Collective clipboard kit, which includes our clinical swallow examination resource. We have a robust and vibrant community of SLPs and mentors to help you out with your toughest clinical cases. Head over to medslpcollective.com now to get your hands on this. The link will be in the description below.